FNA turn malignant out of the total volume of thyroid FNACs, with PTC being the most common thyroid cancer. And this is the kind of algorithm for management that when we are looking at a thyroid FNA, it could be either non-neoplastic or neoplastic. For non-neoplastic, generally, it's non-surgical conservative management, observation, and sometimes a repeat FNA. But for the neoplastic nodules, mostly it is surgery in the form of lobectomy or a near total to total thyroidectomy with or without neck dissection. So frenulum aspiration is the primary modality in the investigative workup of a thyroid nodule with proven diagnostic efficacy. It identifies and triages those nodules requiring surgery versus those that can be left alone or managed conservatively. There are some pitfalls of FNA in the form of false negative and very rarely false positives. And also remember that there are significant risks of thyroid surgery in the form of hypothyroidism, hypoparathyroidism, and recurrent laryngeal nerve injury. All of us know about the Bethesda system for reporting thyroid cytopathology, which was a sort of a revolution in itself, with the 6 diagnostic categories. And we also know that the risk of malignancy increases from category 2 to right up to category 6. And if you look at the category 3, it is around 5 to 15%. Category 4, it is 15 to 30%. And 5 and 6 are quite high. And this is the kind of management which is based essentially on the risk of malignancies that are there. So like I said, there are, for several decades, we have been facing these same problems in thyroid FNA, category 3, category 4, where the differential diagnosis can be hyperplasia or neoplasia, and under the neoplastic lesions, you have follicular adenoma, carcinoma, follicular variant of PTC, and the recent NIFT-P. We also have Hürthle cell-rich lesions, wherein, again, the differential diagnosis could be lymphocytic thyroiditis, PTC, Hürthle cell adenoma, Hürthle cell carcinoma. Cystic lesions, always a problem, wherein it could be a cystic colloid goiter versus a cystic PTC. Lymphoid lesions, lymphocytic thyroiditis versus low-grade NHLs can be a problem, and when you're confronted with some unusual lesions. Category 3 is the atypia of undetermined significance or follicular lesion of undetermined significance, and we all call it as OSFLAS. This represents a major challenge in thyroid diagnosis. And just to show you some cases, for example, this was a case where the aspirate showed mild anisonucleosis, signed out as Cat 3. Here was a case where the nuclei showed a little bit of grooving and again put into category 3 OS, PTC not excluded. And there was a certain cases wherein they were rich in Hürthle cells, and we said a Hürthle cell rich lesion and gave the differential diagnosis, again put it into category 3. Similarly, here is a case of FLAS NOS, where you have these kind of microfollicle pattern lesion. Then we had a FLAS, where we favored follicular hyperplasia, but again put into category 3. This was a FLAS Hürthle cell type, and then we have a FLAS where PTC, the FVPTC is really not excluded. So like I said, what is the proportion of indeterminate thyroid nodules? They approximately represent 8 to 10% of all thyroid FNA. But they're very variable in different series, and this is just from our own data. It was ranging somewhere hovering around 5% of all the thyroid FNACs. In the 2017 Bethesda system, if we see that the most important, one of the recommendations was the introduction of molecular testing, particularly for Cat 3 as well as category 4. So when we come to the ancillary testing to improve the diagnostic accuracy of thyroid FNA, one could do immunocytochemistry. There were quite a few papers which came from the Italian groups. However, this has a lot of issues with sensitivity and specificity, not really recommended. But in molecular testing also, you have a really large range of tests. There's no single test that is recommended. So we have a test for detecting the gene mutation and the rearrangements. Then we have the gene expression classifiers. We have also tests which are based on microRNA analysis. The gene mutations associated with PTC are mostly in the MAP kinase signaling pathway. And as you can see, you have the red PTC gene rearrangements, the RAS gene sitting here, and the RAF. So essentially, all these affect the MAP kinase signaling, and the mutations and the gene rearrangements will lead to dysregulated cell proliferation, growth, survival, and ultimately leading to a tumor. Mutually exclusive mutations are found in 70% of the PTC. And remember, the geographical differences exist in the mutational profile. So like I said, if you look at these three, the BRAF is the most common, seen in 40 with a frequency of 40 to 45% in PTC. Red PTC gene fusions occur in about 10 to 20% of the cases, and RAS gene mutations in another 10 to 20% of the cases. So just a cartoon showing the red PTC gene rearrangement, which again can be seen, like I said, in a proportion of PTCs. And red, the familial cases of medullary thyroid carcinoma can show germline mutations of the red oncogene. PAX8 PPAR gamma rearrangement is another, which is associated with PTC, and it's also seen in 30 to 40% of conventional FC, 30 to 40% of FVPTC, and in a small proportion of follicular adenomas. Now let's look at the RAS gene mutations in thyroid neoplasms. Frequently, they involve the NRAS codon 61 and HRAS codon 61, unlike other malignancies, where KRAS codon 12, 13 predominant. And it is again seen in 10 to 20% of the follicular variant of PTC, 40 to 50% of follicular carcinomas, and 20 to 40% of follicular adenomas. And some people believe that these follicular adenomas, which show the RAS gene mutations, are probable precursors of follicular carcinomas, but we really don't know. But remember that RAS gene mutations marks neoplasia, but not malignancy. Coming to BRAF mutations in thyroid cancer, point mutations are the most common, with nearly 40 mutations documented, and T1799A leading to the V600E amino acid change is the most common. This leads, like I said, to the constitutive activation of the MAP kinase pathway. The other alterations in BRAF include the K601E mutation. So besides this, BRAF mutations can also be seen in anaplastic thyroid carcinoma. There are clinical implications for this. We will see that, like I said, it's very common in 40 to 50% of the PTC, but can also be seen in a proportion of poorly differentiated and anaplastic thyroid carcinomas, where BRAF is detected both in the well and the poorly differentiated areas, indicating that it's an early event in tumorigenesis. But it's not present in other carcinomas and never present in benign lesions. So it is a specific marker of PTC and related tumor types. We have several detection techniques, which include direct Sanger sequencing, real-time PCR, ARMS PCR, and so on and so forth. So what should be the sample for molecular testing in FNA? A very, very important issue. You could have a directly collected sample, you could have cell block, and you could have smears. So what would be your choice? A directly collected sample is very ideal because it gives you fresh cells and you could do DNA and RNA-based assays very well. But the disadvantage is that the cellularity and the adequacy are not assured. Cell block, again, very good. For DNA-based assays, probably okay for the RNA-based assays as well. Cellularity can be assured, but majority of the thyroid FNA, we don't get very good cellularity on the cell block. Smears are excellent for both DNA and, with the current kits, even you get decent quality RNA. So I'd say smears are excellent for any type of molecular analysis. And the added advantage is that cellularity and representation is assured. So this is what many times when a few years ago, we tried to standardize this protocol. So we first look at the slide and we ensure that it is quite cellular. Then this kind of is scraped with a sterile scalpel blade and taken into an Eppendorf tube. And similarly for cell blocks, of course, we cut multiple sections, 3 to 4, 10 micron sections. And then, of course, they are deparaffinized, brought to water and, of course, taken for DNA extraction. And we generally extract the DNA using the QIAGEN DNase minikit. And this is a protocol which most labs can easily do. So from our data, the overall DNA yield in thyroid is pretty good, although some cases may not give you very good yield, but generally the yield is good. And when we compare the direct sample with the cell scrapes, you can see here that cell scrapes do very well. So here's the mean is 62 versus a mean of 129, median 26, and median of 56 nanograms per microliter. So cell scrapes or cytoscrapes that we call them are excellent for yield of DNA. Just a comparison again to show you, and just to show you the DNA extracted, run on an agarose gel, to show you the excellent quality, which you can also measure using the 260-80 ratio, and also do the quantification by nanotron. So coming back to the molecular markers, the BRAF and the RAS gene mutations. So this is our target here. If you want to look for gene rearrangements, again, you have to do it on the extracted total RNA. So just again, a recap of what I had already told you about the percentages of the mutations that can be seen across the various thyroid cancers. PTC, BRAF seen in 30 to 90%. In fact, very high figures have been quoted from the Korean groups, but in our country, it's around 40 to 50%. RAS gene mutations, of course, you can see it in follicular adenoma, carcinoma, as well as FPPTC. TERT promoter mutations seen in follicular carcinoma and also in anaplastic carcinoma. PPAR gamma fusion in FA and FC, and so on and so forth. So we did a very small pilot study, in fact, and then this was the sample, the study design. Essentially, we took cytoscrapes, extracted the DNA and ran it on a using a real-time PCR using the Entrogen thyroid mutation kit, which is a 5-gene assay looking at BRAF, KRAS, NRAS, and HRAS, and these are the nucleotide changes of the mutations and also the corresponding amino acid change with the respective cosmic IDs that's seen. So note that for KRAS, it is codon 12, for NRAS, codon 61, for HRAS, it is codon 12, as well as codon 61, for BRAF, it is V600E. So this is the kind of plots that you actually get. So there are two probes. One is the WIC and one is the FAM. The WIC is against part of the gene, which is an internal control. So for example, here, these are the WIC profiles. The internal control is working, and none of the FAM has shown a signal, which means that this case is completely negative for all the mutations. But here, one FAM tested positive, and this FAM corresponded to one particular gene. So this would be a mutation positive case, and this is completely negative for all the 5 genes that were tested. Sometimes you can land with some problems in interpretation, that you can get or the internal control itself not working. So then you should really not interpret such cases. Sometimes there's a variable rise. Again, you will not. This is an uninterpretable test, and sometimes you can get very low rise. You're not sure. And all such times, you just have to repeat the test. So we reviewed all our cases, selected out the smears, did the cytoscrape, did the DNA extraction, and went on. Just to demonstrate some cases, this was a classical PTC to you, category 6. And when we did real-time PCR from one slide, cytoscrape, and this corresponded to the BRAF V600E mutation. So this was the FAM. You can see the CT value, which was 34 or something, which is positive here, and the internal control has also done well. Here's another case, which again a PTC here, histologically proven, again was positive for the BRAF V600E mutation, shown by this. This is the positive signal. This was a follicular adenoma, which was proven on histopathology, which was positive for an NRAS mutation. This was initially put into category 3 as a follicular lesion of undetermined significance, turned out follicular adenoma, and was NRAS gene mutation positive. Then we had a case which was the cytodiagnosis was a metastatic PTC, category 6. Again, it was in cervical lymph node, but this was negative for all the mutations that were tested. Then we had another case which was signed out as possibly FAPTC, and this showed a BRAF V600E mutation, again histopathology proven case. Then we had a case which was a follicular neoplasm. It had a lot of this microfollicle pattern lesion. HRAS was positive, and on histopathology, this was a follicular carcinoma. So this was again FAPTC, and this showed a positivity for the NRAS mutation there. Another case of poorly differentiated carcinoma, signed out as a poorly differentiated carcinoma, proven on histopathology again, which was positive for NRAS mutation. So we compiled our results and published it in the Journal of Cytology by Ojas, Gupta, Upasana, Gautam. Both of them worked on this pilot project. and Dr. Bishan is the histopathologist here. And so the tidal molecular testing for BRAF V600E and RAS mutations from cytoscrapes of thyroid fine aspiration, a single center pilot study. And I'm just showing you so you could go back to that publication and read it up for yourselves. And so this is just the data from that study itself. So we had 45 histopathology proven cases. So if you look at the mutational profile of the entire cohort in 4 cases, we could not get the sufficient DNA. So you can see that BRAF, no mutation was detected in 45% of the cases. BRAF was detected in 26%, followed by NRAS in 23%, HRAS in 5%, and in 1% in KRAS. So this is the BRAF and the RAS mutations in the different TSR, which is TBS categories. So no mutation detected in CAT2, of course, and we had out of 18 cases, no mutations were detected in CAT3 in 9 cases, but in 9 cases there were mutations: 1 BRAF, 6 NRAS, 1 HRAS, and 1 KRAS. So if you see in category 3, NRAS was the most common mutation that we detected. If you look at CAT4, we could detect mutations in 6 out of 9 cases. 3 were NRAS and 3 were HRAS. In CAT5, we had 7 mutation positive cases. 3 were in BRAF and 4 were NRAS. And then, of course, CAT6, this was used like a control, basically. So we had 17 cases, and 12 of them were BRAF positive, and 5 were NRAS. In the lymph nodal metastasis, we had 10 cases, and mutation was detected in 6. 5 were BRAF, and there was only 1 NRAS. So total, we could see that BRAF was the most positive, seen in 21 cases or 46%, followed by NRAS in 19 cases or 42% of the cases. So if you look at category 3, there were a total of 18 cases, like I said. So when no mutation were detected, the histopathology showed follicular adenoma, hyperplasia, Hürthle cell adenoma, and colloid goiter, as shown here. Whereas in the mutation positive cases, NRAS, where we had NRAS, the histopathology showed follicular variant of PTC, 1 follicular adenoma, and 1 PTC conventional. HRAS positive case, the follow-up was 1 follicular adenoma. We could not obtain histopathological follow-up in the other cases. Similarly, in the category 4, like I said, where we had HRAS, 2 turned out follicular carcinomas. Again, NRAS positive in 2 follicular carcinomas. And when none was detected, we had 1 follicular carcinoma and 1 FV-PTC. Similarly, in CAT5, we can say the majority were BRAF positive, and we only had histological follow-up in 1 PTC, and NRAS was positive in 2 follicular carcinomas. So if we put 3, 4, 5 categories together, so you can see that no mutations were detected in half the cases, but mutations were detected in half the cases. And where the mutations were detected, we had a range. For example, BRAF was positive in FVPTC in 1 PTC, HRAS in follicular adenoma and carcinomas, and NRAS, of course, where FVPTC, follicular adenoma, follicular carcinoma, and 1, we had it also in a case of PTC. So this is just to show you the pie chart of the gene mutations of the histopathology proven cases. So out of the BRAF positive, majority are PTCs. So out of the 12 cases, 11 were PTCs and 1 was an FVPTC. So this is the 45 histopathology proven cases. Like I said, out of the NRAS cases, we had positive cases, 4 follicular carcinomas, 2 PTC, 1 FVPTC, 1 poorly differentiated carcinoma, and 1 follicular adenoma. And amongst the HRAS, there were 2 follicular carcinomas and 1 follicular adenoma. So this is the correlation of the genetic mutation with the histological outcome. You could go into the details in the paper. But I think this slide is very important, where we try to look at the correlation of gene mutation with the histological outcome in the indeterminate category 3, 4, and 5. So as you can see, there was no particular correlation of gene mutation detected with a malignant outcome. However, overall, the sensitivity was 57.1%. Specificity for malignancy was 80%, with a positive predictive value of 80% and a negative predictive value of 57%. So this low negative predictive value and a relatively moderate, I would say, moderate sensitivity and a moderate NPV means that you cannot exclude a malignancy if the test comes negative. But the relatively good positive PPV and the relatively high specificity of 80% means there's a high probability of having a neoplastic lesion which is malignant if this test turns positive. So this is our study had a low NPV simply because we were testing only the 5 genes, I believe. But when Nikiforov et al. Nearly a decade ago have shown that when they looked for BRAF, RAS along with red PTC and PAX8 PPAR gamma, they had again a sensitivity of 63% and an NPV of 84%, but the specificity and PPV were quite high. So ours had a much lower NPV, but our specificity is somewhat comparable. So if I have to conclude, molecular testing is easily performed on thyroid FNA samples, either on a direct sample or on cell scrapes. But if you ask me, my preference is the cell scrapes because nowadays you can also extract both DNA and RNA comfortably from them. The commercially available multiplex RT-PCR kit is very sensitive. It economizes on the amount of DNA. BRAF mutations are predominantly seen in PTC and in nodule metastasis of PTC. And amongst the indeterminate category, molecular testing showed a PPV of 80%, making a very good ruling test. So this is the another paper the paper I referred to, Nikiforov et al. And you could even go into the details of this paper. So this is the algorithm that they recommended that following FNA, the cytology diagnosis. If this was the original risk category based on cytology only, if you did the molecular testing, then you could more accurately predict the risk of malignancy and, help the surgeon manage the case most appropriately. There are also some prognostic implications when you're testing for doing the molecular test in thyroid PTC because BRAF, if it is positive, it serves as a marker of poor prognosis. It predicts for extrathyroidal extension, advanced stage presentation, lymph nodal and distant metastasis. And therefore, if it is positive for a BRAF mutation, the surgeon could go in for a more extensive initial surgery. The patient should be on a more closer follow-up and probably would need higher dose of post-surgical radioiodine treatment and lower suppression of TSH. So this is the 2015 ATA guidelines. And of course, this is we also have moved into the era of next generation sequencing. But just to say that the results can be good, but the cost is extremely high, I would say. So they had excellent sensitivity and specificity, and this is the commercially available as ThyroSeq. And this is just to show you another, the kit from Introgen, which also looks for, apart from the 5 genes that I said, it also looks for the fusions, gene fusions, red PTC1, red PTC3, and the PAX8 PPAR gamma. Currently, we are trying to shift from the 5 gene assay to this, more complete panel, and hopefully it will yield even better